Thank you, Victoria. So let me click on this. Okay, so before we get started with our training, I just wanted to put out some housekeeping rules to reduce distractions and increase engagement. So if you do not have any questions, keep your audio muted. Background noise can be really very distracting for the audience and also for the presenters. And we would love to see your faces. So if you're able, turn on your camera. It's not a requirement, but it's always nice to see a face and put a face to the name. Use your chat. We're going to be here for some time today, so feel free to type in your questions, utilize the chat box, the reaction tab to raise your hands. Definitely provide us with feedback. And also because we're going to be here for some time, we do have some breaks in between, so feel free to move around. So yeah, just wanted to put these out there for you all to know. Next slide, please. So before we start talking about the collaborative care codes, I just wanted to give you all a quick overview of the integrated behavioral health and a quick overview of the collaborative care model. So what you see on the screen right now is the definition. This is the definition for integrated behavioral health, which is a common definition that the Agency for Healthcare Research and Quality, they developed this through their stakeholders' input. So it's the care that results from a practice team of primary care and behavioral health clinicians who are working together with patients and families, utilizing a systematic and cost-effective approach to provide patient-centered care for a defined population. The team here, they'll address mental health, substance use, and behaviors that affect physical health, which are often identified in the primary care visit. Next slide, please. So some of the key elements of integrated behavioral health is important to discuss. And when we talk about integrated behavioral health, there are two very specific models, but we need to understand that no matter the model or the type of integrated care that you want to provide, you have to understand the key elements of integrated behavioral health, because without these elements, you would really be missing a step in access and quality of integrated care. So first off, it should be person-centered team care that is collaborative in nature. So it should not just be a co-located care where you have your behavioral health provider in your office. It should be more than that, where the teams are really learning to work together in different ways, making decisions collectively, while keeping the behavioral, mental, and physical health in mind. It should also be population-based care, where the care has access to shared records. They're able to look at the quality outcomes and measurements and adjust those measurements so that no one falls through the cracks. Keeping that population-based care in mind, there should also be measurement-based treatment to target, and those treatments should be actively changed and adjusted until the clinical goals are achieved. There should also be evidence-based care, which means patients are offered treatments with credible research evidence to support their efficacy in treating the targeted health conditions. These include a variety of evidence-based psychotherapies that are proven to work in the primary care setting, as well as the medications. And lastly, not only should your team your team should work together with patient, but your patient should also experience that one-stop shop where all of their needs are met in one place, so that you're treating a patient as a whole, because our mind is not separate from our body. Next slide, please. So there are some misconceptions about integrated behavioral health. So I just wanted to take this opportunity to clarify some of those here. So integrated behavioral health is not a co-located model. Just because you have primary care services and behavioral health services within the same building or down the hall or separate floor does not make your system integrated. In order to deliver that one-stop shop to your patients, you need to have your behavioral health services integrated into the primary care team, where your behavioral health care provider is counted a core member of the primary care team, working together collaboratively from the same office space. It should not also be about consolidating separate funding for physical health and behavioral health care. Just because you now have a built-in revenue for behavioral health services does not mean your system is really integrated. It is also not about putting the physical health and behavioral health services under the same line of authority. Integrated care, and we cannot emphasize this enough, it cannot be one person's job. You cannot assign one person to be in charge of all things integrated. It has to be a team effort, all working together, having shared goals, building mutual trust, clarifying roles and workflow, and just having strong communication all together. And lastly, simply contracting with a managed care organization to manage both physical and behavioral health, certainly it's not enough to make your system integrated. So none of these elements that you see on the screen here is really sufficient enough to make a system integrated. Next slide, please. So, oh, you're already there. Sorry, I didn't realize. Let's talk about collaborative care model really quickly. So this model was actually developed by the University of Washington. It was originated in a research culture, and it now has been tested in 80 randomized control trials. So it takes a very systematic approach to treat common mental health conditions in the primary care setting. It focuses on a defined patient population of primary care who are already diagnosed with mental health conditions like depression, anxiety, ADHD, and substance use disorder. This model includes behavioral health care manager and a psychiatric consultant, as you can see in the triangle and the image there. And together as a primary care team, they track patients in patient registry, and through that registry, they're able to track each patient and reach out to those who are not improving, and look at, and through that, they're also able to look at the quality outcomes and measurements and adjust the measurements so that no one falls through the cracks. So it's a very systematic approach to treat patients in a primary care setting. The collaborative care model also focuses on patient-centered team care. The primary care provider and the behavioral health care manager, they work collaboratively with the psychiatric consultant to provide both behavioral and mental health services by actively engaging patients in treatment plans, incorporating their goals, and as you know, increased patient engagement oftentimes result in better healthcare experience and improved patient outcomes as well. And in this model, the team must also use data-driven measurement tools such as the registry. And one of the biggest reasons is so that the behavioral health care manager can use that registry to track patients' progress. And so they're able to conduct the weekly systematic caseload reviews with the psychiatric consultant. And that caseload reviews, they focus on patients who are either new to the collaborative care services or those who are not improving as expected under their current care. And this is then gets reviewed by the psych consultant, and they provide recommendations on the treatment strategies to the primary care provider. So overall, collaborative care leads to better patient outcome, better patient and provider satisfaction, improved functioning, and of course, reduction in healthcare cost as well. Next slide, please. Very quickly, let's go over some of the misconceptions about this model as well. And as we all know, there's such a need for psychiatrists, and because this model does include a psychiatric consultant, does not mean this model can be a replacement for the need of specialty mental health. Collaborative care model cannot be a replacement because they are mostly making recommendations to improve the treatment plan for patients. There's a misconception that just because you have psych consultant, you are providing a full-on psychiatric care and can use the CPT codes for billing and reimbursement. It also cannot be a replacement for specialty mental health because the patient and the primary care provider under this care, they do not have direct access to psychiatric services. The patient do not get a visit with the psychiatrist or get to have that one-to-one interactions like you do with the specialty mental health. The behavioral health care manager is really the one who is the mediator here and the one who mainly interacts with the psych consultant and do that weekly caseload reviews and get their recommendations. And they are the one to bring those recommendations to the primary care provider to adjust the treatment plan for the patient. The care under collaborative care is also not long-term. This model is not for patients who are who have highly complex mental health illness that requires long-term care. So it's for those who are able to remain stable with the support that they receive from the collaborative care team and are able to maintain healthy behavior change. And lastly, collaborative care is also not just a curbside consultation or an informal, unofficial consultation obtained by any health professionals. It's very much a systematic approach. And this model requires competent staff like the behavioral health care manager to successfully operate under this model. Next slide, please. And I'm obviously talking a lot in theory. I'm saying if we implement this model accurately, the model, the collaborative care model can be the most effective way of providing quality care to patients who are diagnosed with chronic mental health conditions. But collaborative care is evidence-based. There are many research studies out there on this model. And it's very well studied. So I wanted to give you some examples of the studies done around this model. Their results, they show that this model is helpful in reducing symptoms, improving adherence to treatment, improving response to the treatment, and recovery from symptoms. It also helps to improve functioning and quality of life. And for those enrolled in the collaborative care services, there was a less frequent use of acute medical services and had the highest retention and satisfaction among patients who received services under this model. So just wanted to put that out there for you all to kind of give you an example that this definitely can work in the primary care setting. So with that, I'll pass it over to Kara.
Thank you, Sujina, and thank you all for being here. I'm really excited to, believe it or not, to talk about CPT codes. So I am, and I want you to know that I'm the type of presenter that's really gonna challenge you to engage in this presentation. So I don't want to just stand here and talk at you. I want to have conversations with you. I want your feedback. Catherine and Paula, seeing your faces, I love it. Thank you so much for turning on your cameras. So I want you to first, it looks like many of you know where your chat box is. Open up your chat box on a scale of 1 to 5, 1 being like, oh my gosh, I do this because I have to, but any fee-for-service CPT trainings are boring to me, and this is a boring topic, to 5 is like, this is what I live for. I live for trainings to learn how to bill and code appropriately. Where you at? 1, oh my gosh, help me not fall asleep, Kara. 5, like, I could teach this, I'm so excited about it. Oh, man, this is pretty close to 5. I bet you not a lot of people are going to give me a 5. Okay, great. Whoa. So let me ask this. I also want you to put in the chat, we're in the greater Houston area in Texas. Tell me, what state are you in? New York, Arkansas, New Hampshire. Is anyone here from Texas? Oh, good. Yes. Gregory, I did see you down there. Okay, fantastic. Well, this is great. I'm glad to know a little bit about the audience here. I want to say that, like Victoria said earlier, what we have is just a bunch of information that we've gathered from public domains and have consolidated it and is ready for presentation to y'all. There are different ways the rules are written for each codes in different states. Okay, so Texas has various regulations around the types of professionals that can be utilized, and some of the ways, most of them are very, very similar state by state. But some of the things that I might say, and I'll identify it, I know are unique to Texas. Well, I know happen in Texas. I don't know if they're unique. They may be in your state. So before we move on, who knows in your state under your Medicaid, have they made the collaborative care codes usable for you? Yes or no? Are collaborative care codes, or I don't know, some of the Medicaid, only some of them, that's even more confusing, right? Yes, Caitlin, good. No Medicaid in Arkansas, okay. Verna, yeah, I always get a little nervous when Verna comes to one of my trainings. She's like really the expert. And we have someone here from the AIM Center, also the experts. I just copy off of these people, to be honest. So always good people on these calls to connect with. So let's start with the basics. Now that I know where we're at and but Medicaid, pass the codes for all plans but Medicaid. Oh no. Okay. Who knows what an evaluation and management code is? An E&M code. You can raise your hand. Okay, Catherine, good. You gave me a 4 on this is almost a 5 of what you live for. So you do know what E&M codes are. Anybody else? Do you know what does anybody not know what an E&M code is? Do I need to explain E&M codes? Everybody knows? Okay, I'm going to do a very basic overview. E&M codes are used during evaluation and management visits when you're seeing a provider, right? Usually that is E&M codes are with medical visits, sometimes, well, always with medical visits. And it is really how they code anytime a patient sees a provider, right? You have to have a diagnosis and you have to have an E&M code, which is a procedure code. Is it a 15-minute visit? Is it a 30-minute visit? I might be seeing you for strep throat, but how long do I see you? And it based off of how long I see you and the type of services I provide to you, not necessarily based on your diagnosis, but how long I see you, you always have to have a diagnosis. And how many services I provide to you, I will use a different code. Standard visit codes for primary care are for new patients 99202 to 99205, and for new patients are 99212 to 99215. These are standard primary care visits. So when you go to your physician and they see you for a strep throat, the flu, any other kind of medical intervention, they're going to use one of these codes along with whatever they diagnose you with, right? And for FQs, they don't have necessarily these specific E&M codes. They use something called T codes. And what's equivalent to that is the T1015. Therefore, medically necessary services. It's obviously when we're practicing in the scope of their license, and integrated behavioral health codes should be used along with E&M codes, right? They're not separate standalone codes because you're integrated, so you should be using them along with your standard E&M codes. I want to say something before I move on. We don't share our slides, just so you know. But we will send you out a very comprehensive toolkit that has that's really better than what the slides can offer you, but it will have a lot of this information in it. We've made a couple of amazing toolkits. So who is familiar with what we would call specialty mental health codes? Who's familiar with these codes? Catherine, this is what I live for. Are you familiar with specialty mental health codes? And of course, the AIM Center. Tisha, great. Jordan, okay. So these codes are on the left, are used for the visit code for a regular mental health visit, right? If I have insurance and I'm going to see a provider out in the community and they are going to do an initial assessment with me, they're going to have a diagnosis to go with that assessment, but they are also going to have this code 90791 to go along with this diagnosis because they're doing an assessment. And then each code after that, after the initial assessment, each code that's used is based off of how much time they spend with you, right? So if you do individual therapy, one-on-one with a counselor, a therapist, a social worker, and they spend 45 minutes face-to-face with you, they will use a 90834. Okay. So these are all the codes that are in we call this specialty mental health because we see providers out in the community not operating in primary care and not operating in a medical setting as specialists, right? Just like any other physician would refer someone outside of his care, any other primary care provider, his or her care, their care, then they would be referring potentially to a specialist, right? And so we would say if a physician has to refer them out, they're referring to a mental health specialist. Does anybody have an idea on what's the difference between specialty mental health codes and specialty mental health codes with E&M services, with the evaluation? Catherine, you have to unmute yourself. This is what I look for.
It's who delivers the service. So
Okay.
Prescribers can do the 90792, 90833, 90836. So psychiatrists, psychiatric nurse practitioners, and then the specialty mental health codes are associated with people who are not licensed to prescribe medications. So the therapists, counselors, psychologists often are the ones who deliver the 90791, the left side of the picture.
Yes, very good. Okay. So we have one slide with a lot of numbers and minimal explanations after it. This is going to be a lot of what we're looking at today. A lot of numbers with some words and explanations. Before we move on, what questions do you have? Annie, good to see you. So there are a few sets of codes that we traditionally cover as a part of what we call integrated behavioral health codes, what lots of people call integrated behavioral health codes. And we stick with codes that go within models that are evidence-based. So there are these specialty mental health codes that can be used in primary care if they're used and documented in the appropriate way. And we'll talk about how you can do that as a part of the collaborative care model. There are health behavior assessment and intervention codes that, who's familiar with HBAI codes? Catherine, next time you're teaching this class. Okay, so we're not covering HBAI codes today. That is part of the primary care behavioral health model. And PCBH is a different model than collaborative care that provides integrated behavioral health services in primary care in a different way than collaborative care. And then we've got our collaborative care codes. Who's seen these before? Annie, come on. You have had to see these. Okay, don't be shy. I love it. Paula, have you seen these? No? Okay, cool. I love it. Very good. So this is what we're going to talk about today, is these collaborative care codes. Okay. So before I go on and get in deep about collaborative care, who is working at an organization or an entity that is implementing or trying to implement collaborative care? Use your, yeah, if I can see your face, put your hand up. If I can't, yes, thumbs up, hands up. Anybody else? Trying to implement, yeah. Everybody's trying, I think. Nobody's perfect. Always a work in progress. Anybody else? It's going to be a big learning curve. Doing it. Caitlin, love it. Okay. So Sujina talked about this a little bit. There are 3 main providers for team members, right? Because your patient is one of your team members in this, but 3 main providers as a part of this model. So we have our primary care providers, right? And this is a primary care physician or a oh my God, I got messed up, sorry. A primary care provider, a physician, a pediatrician, a nurse practitioner, a physician's assistant, a specialty provider. So the integrated behavioral health codes for collaborative care are all billed. The collaborative care codes are all billed under the primary care provider. That's where it starts. So as we talk about the CoCM codes, these codes over here on the right, all of these codes are billed under the primary care provider's license. Even though that primary care provider might not be doing some of the work, it still gets billed underneath him if it's a collaborative care code or her, them. Sorry, that's really awful. So the other one is a psychiatric consultant, and that can be a psychiatrist or a psychiatric nurse practitioner. And then let's talk about the behavioral health care manager. Someone put in the chat that they are a behavioral health care manager. Who was that? Or you can just raise your hand and tell me, so I don't have to go back too far. Caitlin, you're doing it, and you're a behavioral health care manager. And Caitlin, what state are you in?
I'm in New Hampshire.
New Hampshire, all right. And Caitlin, what are the qualifications in New Hampshire for someone to be a behavioral health care manager?
So I think that the minimum qualification for my role here was a bachelor's degree.
Okay.
We're in the process of trying to hire a master's level as well as to do like the brief interventions and all of that. So I'm doing more of like the kind of collaboration of doing the weekly consults and working with providers and everything.
Good, thank you. So it sounds similar to Texas. So for Texas, they define who a behavioral health care manager is by saying that they need to be someone that's a qualified mental health professional under the community services initiative in our Medicaid offices. So it'll be very important for you in your state to know how your state defines who can or cannot be a behavioral health care manager. For Texas, a qualified mental health professional under the community services line is someone with a bachelor's degree with a focus that has enough credits to have a major. They might have a double major or whatever, but a major in psychology, social work, nursing, sociology. The list is really long. I didn't have enough room on the slide. So someone with a bachelor's degree that their education has a huge focus on behavioral health in some form or fashion. However, you can also hire someone that's a registered nurse in this position, as well as those that are licensed providers. Questions about that? So we're going to talk today about these codes, and we're looking at them again. I know I showed you a few slides ago. We're looking at collaborative care codes. And when I have the G codes on here, that's the codes that are used under Medicare and often for FQHCs. It depends on the state. So I want you to always remember, whatever state you're in, what Texas has is called the TMPPM, Texas Provider and Procedure Manual. It's all online. I can go in there and read, like it's, you know, a thrilling 2,000-page document, but I can go in there and find out and read how they've written the codes. So as a tool, that is one of the tools that you can use. You can use your state Medicaid as a tool. That's how we built these trainings, is in coordination with our state Medicaid office. As a tool, you can use whatever the state defines on how they qualify things. And it should be documented and accessible in some form or fashion to you. So we're going to talk about these collaborative care codes. We're going to talk about how do you use those specialty mental health codes as a part of the collaborative care model if you are able to. And really, it gets really complex, but it gets into this reality of if you are a licensed clinician, like an LCSW or a psychologist or an LPC in the state of Texas, those are considered billable and reimbursable for 90791, 90832. You can use those codes and sometimes get a higher level of reimbursement. So we're going to go through that a little bit more because I know that we all want to do great work, but we also work for entities that want to make sure we're getting paid the maximum, the most beneficial amount for our services. So the collaborative care codes are a bit different than most CPT codes. Most of those, so if you remember those codes that I was talking about in the beginning that are E&M codes or specialty mental health codes, they had times after them, right? And these also have times after them. So traditional visit codes, when a provider has a visit with a patient, they get billed on how much time they spend with that patient during that one interaction, only one interaction. So, and it has to be 50% of the time. So that's why you might only see your provider for 7 minutes, because he can bill a 15-minute code if he spent 7 minutes with you. It's 50% of the code plus 1 minute. So if he spends 7 minutes with you, he can bill a 15-minute. Him or her, they can bill a 15-minute code. They can bill a 15-minute code. Paulette's clicking, I see. Right? So this is the same kind of for collaborative care. So your 99492 code is similar as it's 50% plus 1. And we'll look at that a little bit more on the next slide, but it's completely different because it's not based off of one interaction only face-to-face with the patient. It's based off of accumulated amount of time throughout the month that the behavioral health care manager spends on working with the patient or working with the psychiatric consultant to support the patient, working with a primary care provider to support the patient. So that's how these codes are completely different, right? Rather than a 7-minute interaction, one-on-one patient with provider, that's all I get. If I see you tomorrow for another 7 minutes, then I get to bill another code. If I see you the next day for another 7 minutes, then I get to bill another code. Not for collaborative care. It's the month of June. How many minutes have I spent as a behavioral health care manager on a patient? And I add those up, and it should be 50% of 70 minutes plus 1. So what is that, 36 minutes? It should be at least 36 minutes so I can build this code. Does that make sense? Does anybody need any clarification? The way that this is different is when it comes to the FQHC rule, they don't get to use the 50% plus one. They have to use the entire 7 minutes. If you are at a rural health clinic or federally qualified health center, you can't use the 50% plus one. Yeah, you cannot double bill, that's for sure. And that's your first month, right? Subsequent months, it's a little bit different code. It's a little bit less minutes. And then if you spend 81 minutes on your first month with a patient, you can use the add-on code because you're using 50% plus one of this CoCM add-on code. You can also add 99494 to it. Compiled over an entire month, right? You have to use the full 99492, the full 70 minutes before you can bump into the add-on code. So that's why we say with these codes, for like the 70-minute code, you need to spend between 36 and 70 minutes with a patient. Okay. We're going to talk about the time again. Even though the billing is under the primary care provider, that primary care provider, all of these codes go under their license, but not based off of the time that they spend. It's based off the time that a behavioral health care manager spends with them on a patient, right? So again, it's billed off the time that is spent by a behavioral health care manager. The time, the CPT rule, this is the general CPT rule, is that it's billable for services at 50% of the minute time plus one, unless you're an FQHC. The add-on code is for each additional 30 minutes and can be listed with either your first month code or subsequent codes. Annie, sometimes I see you shaking your head and smiling, and sometimes I just see you smiling. I'm like nervous that I'm getting it wrong. If I am, then please say, actually, to help clarify, please, Verna, if I'm, it's a lot of rules to understand. And a lot of nuances. So here's the other really rule and nuance. The time rule does not apply to the general behavioral health code, which is 99484. I didn't talk a lot about that, but it is 20 minutes of the clinician's time to do follow-ups, care planning, facilitation, and coordination of care. So sometimes you have to what you really need to do is make sure that within your electronic health record, there are certain things that are automatics. And if someone's doing something under that would be allowable for one of these or allowable for one of these, that your system has a workflow that can help you auto-populate those codes. So you say, yes, I'm doing this, I'm doing this, I'm doing this. It gives you the time and you auto-populate. Really hard to do. I would say one of the biggest challenges that people talk about with CoCM is documenting time. You have to write down every time you spend time on a patient. That takes time. I don't think you can charge off counting time as time. But And again, the FQs and rural health clinics are required to meet the full 70 or 60-minute time range for those G codes. Are we tired yet? Take a deep breath. So let's talk about what has to happen as a part of that first month. This is the 99492 or your G0511. If you're an FQ, the first month of work. If you're not an FQ, how much time do you have to spend? What's the minimum amount of time? Someone put it in the chat. If you're not a federally qualified health center, how much time do you have to spend working on a patient with a patient to be able to bill this 99492? Yay! Good job. 36 minutes. Very good. If you're an FQHC or a rural health clinic, how much time do you need to spend? 70. Way to go. Y'all are passing the test. So first, the primary care provider needs to introduce the program and really engage the program in the treatment modality, right? The primary care provider can't say, hey, Paula, or hey, Tisha, come in and see this patient, talk to them about collaborative care. No, the provider has to do that. The primary care provider has to initiate that conversation, ask the patient if they're interested, explain it to them, ask the patient if they are willing to participate, right? So that has to happen by the primary care provider. Then the initial assessment of the patient must include a validated screening tool because collaborative care is supposed to target a specific mental health condition and show improvements over time based off of interventions on that mental health condition. You have to use validated screening tools to make sure that you are proving that there are improvements over time. So common ones, right, are the PHQ-9 or the GAD-7. Those are common tools that validated screening tools that you can use if you're going to focus on depression for the population that you're serving. If you're going to focus on anxiety for the population that you're serving, you'll want to make sure that that happens right away, right? And then you develop an individualized treatment plan. So you want to do an assessment, use validated screening tools, and then a treatment plan. Then you need to enter the patient into the registry. You have to have a registry. The registry is where you document and show improvements document your visits, show improvements over time on your validated screening tools. And that's the document that you use to review with a psychiatric consultant. And then you review what has happened with that patient with the psychiatric consultant. This is a new patient. This is where they're at with their screening. This is what we've developed as an individualized treatment plan. And this is where we're starting. And the psychiatric consultant can say, great, or they can say, let's add this, let's change this, let's see if they're willing and the PCP wants to do it this way. It might create some more significant improvements for the patient. Okay, so this all needs to happen the first month. And then interventions, right? You can also and should also start interventions. The earlier you start interventions right after the initial assessment, the more likely you're going to keep the patient in the collaborative care model that you're providing. Questions? I have a question. Do you have to spend all of your 36 minutes on the patient during one interaction? No. It can happen over several interactions throughout the first month. Good job, Tiffany. Thank you. So our subsequent month, we are going to continue to track patient follow-up and progress on the registry. So month 2, you're going to say, oh, this is month 2 for this patient. Let's put them in the month 2 category. And we are going to, again, review what's going on with the patient, with a psychiatric consultant. And I will say that you will review as needed. It is not required to review every single patient, but you will be able to review patients with the psychiatric consultant as needed. So you still have to, no matter what, those calls with the psychiatric consultant have to be every week. Have to have a standing call every week with a psychiatric consultant. Whether you're going to review 5 or 40 patients, that's up to you, the PCP and the psychiatric consultant. You still have to have your meeting every week and document that you're reviewing cases, some number of cases. You have to continue ongoing collaboration and coordination with the PCP. You're billing this all under his license, so his or her license, their license. So you better be talking with that person on a regular basis about how the patient is doing, what the psychiatric consultant is recommending. And then obviously add progress and recommendations for changes with the patient as you are getting feedback from the psychiatric consultant and the patient. So then you also need to be providing interventions, ongoing interventions, keeping up to date with what's happening with the patient, if they're following their treatment plan. And again, you will be using these validated screening tools as a part of the work for the month with the patient to be able to use this code. Are we tired yet? Okay. So just so you know, I haven't been able to exactly figure out the reimbursement rates for Texas Medicaid. I would recommend that you, if you want to know how much your Medicaid office is going to reimburse for those Medicaid codes, I bet Verna knows Texas is. We should just have her fill this in. Texas is low, as always. Your state may be lower or higher. Well, it's probably not going to be higher than the Medicare rates, but within Texas, these are the ranges for Medicare rates. So it's good to know within your state what Medicaid reimburses. Also, Medicare reimburses on a range based off of some formula they use for different states and different regions within states. So these are a range for us in Texas because our state is so big. There's multiple regions within our state. So Medicare will reimburse a region in our state differently than they do another region and differently than they do in your state. I think it has to, my assumption has to do with cost of living and things like that, but I have no idea. But it's a range. It's important for you to know. You need to know if you're going to be able to have a return on investment with this, not just for your patients, right? But to actually pay for and sustain the program. So again, it's based off of the provider rates, and 100% of a physician's fee for Medicaid is going to be different than 100% of a physician's fee for Medicare, right? So a physician's fee for Medicare on the high end is $158.31 here. With Medicaid, I guarantee you it does not match. So the physician's fee for Medicaid is going to be lower, probably even than 147 in the state. We're probably hitting at like 125, guess again. But it's the physician's rate, right? And 100% of Medicaid is not the same as 100% of Medicare, because Medicare is generally paying more than Medicaid. So if you're doing this with a physician's assistant or a nurse practitioner, it's going to be 85% in the state of Texas, it's gonna be different in your state of Medicare. I'm sorry, 85% of Medicare, 92% in the state of Texas of Medicaid. So all minutes, we said this before, that count towards the threshold are of the work documented by the behavioral health care manager.
I gotta run the noise. I'll be back. I got it on my phone.
So the codes are going to include the time. Because the psychiatric consultant is working with the behavioral health care manager and going to include the time of the psychiatric consultant, but they don't get to bill separately. Whatever the physician gets, if they're using as they have to use a behavioral health provider and they have to use a psychiatric consultant, they have to figure out a way within the way they're reimbursed to pay both of those people. And again, for the state of Texas, the behavioral health care manager must have a formal education or specialized training in behavioral health. But we do not. In Texas, we do not need to be licensed. Oh, thanks, Verna, on your good lucks. And this is again how we separate the codes for FQs and other providers. So as I said before, these codes are under the primary care provider, unless everything is, maybe you could do something a little bit different. Unless your behavioral health care manager is a licensed provider and you want to, I think it was Caitlin, maybe, you want to hire someone that can do really therapy sessions, then you can hire someone with a license and use some of the time under these codes. You can't double bill, like Gregory said earlier. You can't say, you can't count minutes of a code for CoCM if you're going to bill under the 90791. You can't count the same minutes, but you can divide out the minutes and decide which way is a better cost benefit for you. Yes, Catherine. You have a question.
I have 1,000 questions, but let's just start with the primary one regarding that. So I really appreciate this. I am also curious how like logistically is the tracking done if you have an EMR from the 80s? Because I will also tell you all the time it takes to fill out an Excel spreadsheet and send the Excel spreadsheet to the billing and coding, and then they have to send it back and tell us what we forgot. And it's documented somewhere, but they're not really sure where. And does it go into the documentation as a clinician, billing individually, or does it go into the case management documentation? I would love to know logistically how people have navigated this.
What you are saying is not uncommon. Everyone has the same challenge. Annie, do you have any additional insight on it? Because the AIMS Center, I know, has built a registry. It's a bit like a spreadsheet, maybe. Annie, do you want to talk about what you all do? Are you able to do
I only have, I have the most experience with Epic, and we used episodes of care, and there's a few different ways you can approach tracking minutes using episodes of care. So if your EMR has that capacity, that's typically the easiest. But I've also worked as a BHCM years ago and tracked it on a spreadsheet. So I know that, but yes, if you are able to license the ACT, the AIMS caseload tracker, then there's a feature that tracks minutes, and that makes it pretty slick, but they still have to be documented within the EHR. The minutes still needs to be documented, but as far as cumulative at the end of the month, it does make it easier.
So Daniela said that was always her issue with tracking. How do you track the time it takes you to track your time? Doesn't count. You can't track it. Or you can't bill for it at least.
And I'm pretty sure we can't add it to the time.
Correct. You can't add the amount of time I spent tracking my time.
That was actually why ours failed.
Yeah.
It was taking more time to track than it was to actually do the CM, like the coordinator stuff for our nurse. And she got really frustrated and just gave up on tracking it.
Yeah, which is not good.
So
And
yeah, if there
And
are
then you can't bill
tools,
for it.
if there are things that you all have built into your EMR, can you send me your name back channel and your contact? I'd love to talk to you, but it can't cost money. Because nobody will give me money to spend. But I would really like to have, like, this stuff is so interesting, but the logistics of it are where we get stuck every time.
So Catherine, do you know that CFHA, are you a member of CFHA? Yeah, they have a specific group and track that is kind of like a ongoing learning community that discusses some of these challenges. And I know tracking time has been a huge topic that they've been covering. There are more people in that group that are doing collaborative care. So I would highly recommend that you engage in that group. That's where we also, yes, join the CoCM special interest group with CFHA. So sorry, I don't have those magical answers today. I wish I had a way to solve that problem, especially for providers or people that are really slim on budget, because it's painful. Other questions? Catherine, you said you had 1 million. I'm happy to answer more now. That was it?
Oh, is this the question part of it?
Yes.
That
For our first phase, we're going to go into practicing our second phase in a little bit, but for our first phase, yes, this is our question time. Catherine, did you have more questions? So at this point, I'm going to give everybody like a 5-minute break. But before I move on, I want to see a thumbs up from people on your square to know if you're back. You back with us? Jordan, thank you. Paula, wonderful. I'm sorry, that was Tisha. Tisha, thank you. Dr. Trammell Harris, wonderful, thank you. I have 2 Jordans, that's the same person. Caitlin, David, Tiffany, Patrick, Amber. Are you with us? We're going to be doing breakout rooms, so we'll need to know who's actually still with us to do breakout rooms appropriately. But we're not ready quite yet for that. So I want to talk about, Amber is on as well. She's in the same building with me. Wonderful. Good. Amber is here. Patrick, Tiffany, Caitlin, good. I'm glad you're still here. Good. Thank you, Patrick. David, you still here? You've been very quiet, David. No worries, Patrick. Thank you. Good to know. So we're going to talk about this patient that has come to your clinic and has talked to the PCP. We'll set it up. Good. Talk to the PCP about insomnia, having headaches for the last 5 months. The patient has been waking at night, up early in the morning, during the day, she feels exhausted, has difficulty managing work relationships, and has been tired, and has tried to take, has tried to begin exercising again, but it hasn't really helped. The PCP administers the PHQ-9 and it is an 18. So she is negative for suicidality, but she is also negative for suicidality. So they did a suicidality test on her. The PCP talks to Ms. Z about enrolling her in CoCM to introduce her to the behavioral health care manager. And Mrs. Z gives consent. Okay, so let's talk about the code that is or is not allowable under CoCM for this. So you would not, for this face-to-face interaction of the provider with the patient, you're not yet using the CoCM codes because the provider has introduced the patient to the model, but the patient hasn't been enrolled in the program, right? But you have your traditional E&M codes, and that's what you would use. The provider would use their traditional E&M codes and be able to do this interaction and bill it that way. Okay, so you're not yet using your CoCM codes because, again, the time spent is not based off of the provider's time, it's based off of whose time? Whose time is it based off of? IHCM, good job, Tisha. Thank you so much. You don't use this for behavioral health care manager. So then the behavioral health care manager sees the patient for warm handoff to engage the patient and schedule a time to fill out intake in a few days. And the behavioral health care manager enters the patient into the registry. So what do we do here? So again, on the same day, we are looking at the initial visit with the PCP is not billable for CoCM codes, but we saw the patient for 15 minutes and did about 5 minutes of work on the registry. So the behavioral health care manager records 20 minutes of your time, their time towards CoCM. And then you get into whether you're going to bill under just CoCM codes or whether you're going to bill under psychotherapy codes because you have a licensed clinician that can also bill under psychotherapy. But none of this is psychotherapy. None of this is an initial assessment under psychotherapy codes. This is all CoCM. So whether you're a licensed clinician or you're a behavioral health care manager that's not licensed to do psychotherapy, you will document 20 minutes of time for time spent with the patient and in the registry. Do I sound like I'm saying it right, Annie? Yes, okay, good. Okay, so now the same month, you have a follow-up visit. Behavioral health care manager does a comprehensive assessment with the patient, learns more about irritability over the last 6 months, does this really kind of initial assessment of what's going on, does some screening tools, and those are all negative on the other screening tools, but has the preliminary diagnosis of major depression, starts with some treatment planning and begins to talk to the patient about, because the patient's complaining of pain, between depression and chronic pain. So this is your now, as a medical team, third interaction with the patient. First one with the PCP, the second one to really enroll the patient in the program and put them in the registry. And then this is your third interaction just a few days later. So if for this visit only, you spend 45 minutes with the patient and 5 minutes in the registry, and you have some options here, and it depends on your licensure, right? If you're a licensed clinician, you have some options, and you should look at what is most reimbursable for you. And if you're a licensed clinician, you can do an initial assessment under the 90791, those specialty mental health codes, for the time you spent in the visit with the patient. Or, because you're doing this initial assessment, and then you get to mark 5 minutes towards collaborative care. Or if you're not licensed, and if you choose to do 50 minutes under CoCM, you can do that. Are we confused? No. At least I can see one person should be okay. Okay, so we have more interactions with our patients. We talk to the psychiatric consultant about our patient. They're presented during the normal case review. The psychiatric consultant recommends with the primary care provider on what they can maybe prescribe for the patient, and then give some recommendation and asks to repeat the screening in a couple of weeks, in 4 to 6 weeks, and then the behavioral health care manager again meets with the patient. Does some problem-solving sessions, tries to target some goals for our patient to get out of bed, and begin to engage in some social activities, and the patient agrees to talk again in 1 week. By the way, you can do this over phone too, for CoCM. Doesn't all have to be in person, face-to-face, it can be over the phone or telehealth, which would be video conferencing, which I would say is probably if you're not going to do it face-to-face, video telehealth is a great option for you and a really great option for your patients. So March 7th and 21st, we've got all this stuff. We spent 5 minutes, and this is why people have a hard time with this. The registry piece and the tracking of time, because it's a lot to think about, and you can't get paid for tracking your time. So you have 5 minutes of prep time for meeting with a psychiatric consultant. You have 10 minutes of consultant time. You have 5 minutes of registry work, right? None of those are billable towards any psychotherapy codes. It's all billable under CoCM. So if you're a licensed clinician, you can not bill any of these codes under psychotherapy codes. You have to bill them all under the CoCM codes. And again, if you're not licensed, you have to do it all under CoCM codes anyway. The 21st, we meet with the patient and we have a 30-minute session. So we can use a 30-minute psychotherapy code and 5 minutes on the registry, or 35 minutes towards CoCM. And again, if you're not licensed. So your summary for March gets really convoluted. And I would say once you're in this, it doesn't have to stay convoluted every month. You kind of know where your reimbursements should lie. You'll get an idea. You won't have to go through, do I do it this way or do I do it this way this time? Do I do it this way or do I do it this way? You'll get in place all the things that you need if you're licensed to do it differently. So the summary of our visit, our time as a behavioral health care manager on our time on collaborative care codes we had 2 E&M visits, 2 visits with the provider. Anyway, we had a 45-minute session with the patient. We had a 30-minute session with the patient. And so 75 minutes of behavioral health care managers activities. Right, so you can use, obviously with the 2 PCBP visits, you use your traditional E&M codes. With your 90791 and 90832, you can charge 30 minutes of your time. And then you would also use, because you have 75 minutes of the behavioral health care manager's time outside of interacting with the patient, you can use your first month, 99492 for the first month, or all these other kind of strange complications, right? Or you get into, we're only going to use the CoCM codes, by the way, gosh darn it, that's much easier than figuring out all these other codes. But what I want you to know is that you leave 20 minutes of unbilled time on the table. If you're licensed and able to be a licensed provider as a part of CoCM, if you only use your CoCM codes, you'll have 20 minutes of time that's not billable. Okay. So that's where it gets really complicated, and you're going to have to figure out, how do we pick, one, the type of person that we hire for this? Are they going to be able to stand documenting their time all the time? And if they're going to be licensed, how do we make sure we're not leaving billable time on the table? Does that sound right, Annie? Okay. If you say no, I won't be offended. All right, so now we're ready for a Zoom poll. Okay. So, thanks to Gina, you're going to watch this for me, or is it Victoria?
Victoria will do it.
Okay.
Are y'all able to see it?
I cannot see it, but I don't know if that's someone for Victoria.
Yep, okay.
Yes, people are saying they can see it. Okay, good. I can't see it. Why can't I see it?
Because you're a host.
Okay. So, true or false? When providing care for CoCM, within the CoCM model, a primary care provider's team should not include a consulting psychiatrist. True or false?
So we have a answer so far. I'll give folks another couple seconds. We have 4 people that haven't. We have 9. Okay, I'll leave it at 9. End poll, share results. Are you able to see it, Kara?
No,
No.
tell me.
So we had 9 out of 9 answer false.
Yay! Way to go. Way to go. All right. Maybe we can get 11 people to respond to this one. Collaborative care is a form of treatment that tends to take 6 to 9 months for common conditions such as depression, anxiety, ADHD. True or false?
We're at 4 out of 12. 6.
Woo, halfway there.
7, 8, 9.
With the same three. Are you there? We need your participation. We're gonna put you in rooms in a minute, and it'll be awkward if you're in a room with one other person and nobody talks.
Okay, I'll end it and share. We're at 9
Okay.
still.
Okay,
So we have 6 out of 9 who said true and 3 out of 9 that said false.
okay, so the answer is true. 9 to 12 months, 6 to 12 months, somewhere around there. It's supposed to be a program that doesn't keep patients on forever and ever. Graduate patients and they go into remission or sustaining. Because this is a model that is supposed to open up new slots all the time, right? We need to keep the flow because the demand is great. We're always adding or graduating patients off and adding new patients, graduating patients off as we track and measure them and they show improvements in these standardized screenings. They're able to get to a point where they're stable and don't need to be active in the program. That doesn't mean you never talk to them again. You might check on them every now and then, but they're not actively participating in the model. And it is intended to target a specific diagnosis within your practice, and it has to be a behavioral health diagnosis. Okay. Other questions? So we're gonna maybe just do 3 rooms because our numbers are low. So we're gonna do 3 rooms. We're gonna put some scenarios into the chat. And are we going to give them a toolkit of some sort so that they can look at it? Oh, Tisha, we're gonna miss you. Are we gonna give them a toolkit to use for help, or is there one? Yes? Okay, good. So we're gonna divide you, let's do 2 rooms because we have some people that I'm not sure are really actively engaged. I just wanna make sure that it's meaningful in those 2 rooms. And we're gonna have you review your case and come back, make some decisions on how you would bill for these individuals, what codes you would use. So if you see on your PowerPoint that's in your chat, there are different scenarios. So if you're in room 1, you collectively work together to look through the case and report back to us which codes you'll use. So if you're in room 1, you do scenario 1. If you're in room 2, you do scenario 2. Okay, are we ready for the rooms? Yes. Okay, so we're going to send you off. You should have something pop up on your screen that says room 1. Oh, we didn't.
Thank you, Kathleen.
Hey, everyone. How'd that go? I know I think somebody had some problems with accessing and viewing the PowerPoint. I apologize for that clunkiness. But we're here now, and maybe we can just talk through some things if it became too challenging for y'all. Who did this one? Annie, a 50-year-old female.
We did.
Okay. Anna, a 50-year-old female. Annie, and your team. You're not a 50-year-old female, I'm sure. Do you want to talk about what you did here?
Sure.
And call on your other teammates if you.
I took notes and shared my screen, so I'm the only one who can see it right now.
Okay,
So-
great. Can I let you share your screen and you can just?
Yeah.
I will stop sharing. Oh, you can share your screen. Good. Go right ahead.
So this is how we mapped it. We started on a roll with 994, or feeling a typical first month, but then realized that it didn't add up to 70 minutes. But we also were a little confused as to whether, because the 50% plus one is not for, it's not an FQHC or a rural health center.
Correct.
So we weren't sure if we should just do, if it would be 50% plus one, or if we would use the 99484 for that first month.
Well, you can use the 50% plus one.
Okay, so then we probably, so then it would be 5, 25, 30. So no, oh yeah, because it would have to be 36, sorry. That was the rationale.
Yeah.
Math on the spot. Okay, so it would be 36, so we couldn't do that. So that's why we chose 99484 for 30 minutes. And that's the total for April, and then added the psychotherapy 90791 for the initial assessment and follow-up, and then just the non-billable, we would lose not much, nothing, but and then the second month, May, was pretty much the same across the board is how we were, except for the first session of 90832.
Yeah.
Because that would be a 30-minute psychotherapy, 50% plus one.
Yeah.
So that was the only difference for month 2. Otherwise, CoCM codes.
Cool. So yeah, you can see sometimes it's gonna matter, sometimes it's not going to matter. And again, you'd have to look at what is the most productive strategy for reimbursement for your clinic. So group 2. Thank you, Annie, and group 1. Group 2. Do you want me to share my screen? I know you have troubles with all that. And talk me through what you did.
So I guess for this one, we had kind of like looked at, it looked like only that first one, the initial intake and Vanderbilt assessment, would have a potential of like the psychotherapy. And with the remainder from that 45 minutes. So like with the remainder, we were at like 85 minutes for CoCM codes for the month. So we kind of deducted 1 minute because so there's this initial 70 minutes, right? Oh wait, hang on. So now I think about it, sorry, it's initial 70 minutes, not 60. So I guess it would be the initial 70-minute code of the 99492. And then we would actually have to deduct 11, wait, no. We would have to deduct 21 minutes, I guess, from that initial 45 minutes as well to get enough billable time for the 30 additional minutes of the 99494. And then we would have 23 minutes left, I think, or.
So I have a question.
Yes.
When you say deduct minutes from the 45-minute initial
So
visit.
taking, because that 45 minutes total could be used for psychotherapy, but so that we could also use that time towards CoCM for that extra 30 minutes. So we'd have to get 16 minutes for that additional like 30 minutes, right?
I just want to make sure I'm not, and I apologize. I know this some had to do with y'all's challenge of screen sharing. And so for this one, would you have put in a 90791? And then what's the first, I don't memorize code. What's the first code for 45 minutes? And then the first month code is 990. 8
492.
99 492
492.
at 5 minutes, right?
Okay.
Right. So
Yeah, I guess that makes sense then. So then you couldn't use any of that 45 minutes for CoCM.
no, you can't say, oh, we're going to charge 30 minutes to 90791 and 15 minutes to CoCM. You can't do that. You have to pick one or the other.
Okay.
This would be 50 minutes. That's what I thought you were saying, and I'm glad I understood. I apologize for not. But yeah, you can't split the time between one interaction. Yeah, for that one interaction, you have to choose where you're going to do it.
Okay.
So this would be 99492, right, at 20 minutes. And then again over here, right? The other time that you can use your psychotherapy codes is here. Right, because you have 30 minutes with the patient and the parent, so that would be a family code. So for me, it would be again, we're going to do 99492. 10 minutes. 99492. 20 minutes. And then your 99492 at 5 minutes, right? So you have then for your 99492, 20, 30, 40, 50, 60 minutes. So you would be able to charge 60 minutes of CoCM codes to this. And then on top of that, you could charge the 45 minutes under the 90791. And then what's the, Annie, you know all the codes. What's the follow-up code for specialty mental health?
Or with family,
Yeah.
or just with family one?
Yes.
So it's not 90832. It would be 90846. Oh wait, with patient present 90847, sorry.
So you can charge your full 60 minutes for your CoCM codes, and then you can charge on top of that the 45 minute of 90791 and the 30 minute of 90847, right? But if you did this, we have 10 minutes here, 20 minutes here, and 35 minutes here, 50, 60, 70, 80, 90, 100, 135 minutes. So you'd have 60 minutes plus a 30-minute add-on code. But then you would leave whatever that math is. 5 minutes on the table unbilled. Is that right, Annie?
I think so, yeah, except for the second line, I think it's just 15 minutes total,
Oh, yeah, you're right.
but otherwise 50. Yeah,
So again, I know it's very complex. But this is how you need to understand the codes and understand how you're billing what to whom. And based off of the licensure, it's going to be different. Questions?
I do have a question.
Yes, ma'am.
Sarah. Where do you learn all of this? I mean, I am Medicaid provider. I have not provided Medicaid service, and this does not encourage me to start that. But where I guess you hire somebody who can do this. I guess it is very, I have EHR software, so. But yeah.
Yeah, I spent a year working with managed care organizations, payers, HHSC, and a consultant learning these codes.
Wow. Okay.
Okay. So yeah, it's not easy, but what we have done for this is offer this training, and then after the fact, we'll send you an email with several tools that will help you read. You can read through and learn and use these tools, right? Like as we were sitting here and we moved to like, what codes do we use? Like, I don't have this stuff memorized, right? Everybody
Right.
it. Annie has more memorized than I do. She's probably been doing this longer than I have. So it takes really being in it deep to learn it and using tools along the way. Quick reference guide we'll send you and some other information about CoCM and billing and things like that. We also have a Project Echo series. So we have a whole series of learning around collaborative care. So you can sign up for those, and all of our classes that we do virtually online are free.
Okay.
So there's the registration for those.
Okay.
And we have one on value-based contracting and value-based care, which you would think because it's value-based care and not based off of time spent with the patient that you will have to do a lot around coding, but guess what? Sometimes it's more. So it's good to learn.
Yeah.
You may or may not want to participate in such things.
Yeah. That is the challenge.
You can also set up workflows. People like the AIM Center is really good at helping support people through this process. CFHA also has good resources and tools, and so does Mental Health America Greater Houston. So the more you can use people as tools, not in a bad way, I'm sure you don't mean it that way either, but
Right,
like build
right.
relationships, make connections.
Sure.
And that's how we all learn and try to figure out this mess called billing and coding and reimbursement.
Wow.
It's nothing simple.
Right. And the previous video trainings are available, because this is the only one that I mean, by the time I was aware of it, this was the one that I ended up participating in. So are the others available?
Yeah, so if you go to our website, you'll find links to playlists, and those playlists have like all of the previous trainings on it. And you can like pick which ones you want to watch. So, and I'll include that link in the follow-up email too.
Okay, great. Thank you so much.
All right, everyone. Well, we're 3 minutes past time. Usually I like to try to end early, but this was a lot of information, but I appreciate all of you hanging with me. Appreciate everybody's help. Annie, thanks for your help. and engagement and feedback along the way. And reach out to us if you have any follow-up questions.
Thank you.
And please fill out the evaluation survey, which I'm going to send you the link for in the follow-up email. That'll really also help us, with feedback and really fine-tuning these presentations.
Great. Thank you so much.
Thank you all. Have a good day.
Thank you, everyone.